Hi, the purpose of this video is to demonstrate the assessment of the abdomen. Our patient is a 25-year-old who denies any abdominal discomfort, vomiting, diarrhea, belching, jaundice, or any weight change, gain, or loss. He denies any blood in his stools or urine. He denies any fecal or urinary incontinency. He denies any peptic ulcer disease or inflammatory diseases, hepatitis, or cirrhosis of the liver. He denies any urinary tract surgery or injury. He denies any major illnesses, cancer, or kidney disease. He denies any cancer history. Patient's family medical history is negative for any of the above. The patient does not drink alcohol or do any recreational drug use. The patient does not smoke. The patient denies any exposure to any infectious diseases, toxins, and any travel outside of the United States. The patient denies any trauma, and he's presently taking no medication. Do you agree with this history?
Yes.
All right. The first part of our assessment of the abdomen is to do an inspection. Normally, you would have the patient undressed. For the purpose of this video, we're going to leave the shirt on. So prior to videotaping, I assess the patient's skin. I want to look for the color. It should be pink. It might be a little paler than the rest of his skin if he doesn't expose it to the sun. You want to look for symmetry, venous return. You can compress a vessel, and when you let go, you should see the venous return. If it's above the umbilicus, the venous return should go towards the head. If it's below the umbilicus, the venous return should go towards the legs. And any surface motion. Sometimes you can see the peristalsis of the intestines. You also want to look for any masses or hernias. After the inspection, we want to auscultate. We want to use our stethoscope, the diaphragm part of the stethoscope, and we're going to assess all the quadrants, the right upper, the left upper, the right lower, and the left lower quadrant. We're listening for bowel sounds. They should be present. They should be irregular sounds. And you can have between 5 to 35 a minute. Then next, we're going to assess for any bruits. With this part of the exam, you use your stethoscope, you use the bell part. We're going to listen in the epigastric area first for the aorta. Then we're going to move down to the right and left renal artery. And then we're going to go down further for the right and left iliac arteries. And then finally, we will be going further down and listening to the right and left femoral arteries. So first we're going to listen to the aorta, and then we're going to move down a little bit to listen to the right and the left renal arteries. Then we're going to move down a little further to listen to the right and left iliac arteries, and then down a little bit further to listen to the femoral arteries. A bruit, if you hear a bruit, that would be a harsh sound. Sometimes it can be intermittent, and it usually means that there's blood flow turbulence. So really, if you detect a bruit, you'd want to investigate further. The next thing we want to do is we want to percuss all 4 quadrants of the abdomen. We want to check for tympany and dullness. Dullness is heard over organs and solid masses, where the tympany is heard in the abdomen because there's air in the stomach and air in the intestine. So I would use my dominant hand, my middle index finger, and I was striking the finger on my other hand. And you go up and down the abdomen. Tympany would be over air. If you heard any dullness, that would be over organs or any masses. You also want to inspect for tone of the abdomen. Next, we're going to check for the liver span or the liver size. To check this, you go to the right side where your liver is, to the right midclavicular line, over an area of tympany. So you want to make sure you don't go over a rib. And you're going to percuss upward until you hear dullness. So right about here, I hear dullness. I would mark the spot And then that would indicate that's the lower border of the liver. Then to determine the upper border of the liver, I'm going to percuss at the right clavicular line around the third intercostal space. So you want to find your third intercostal space. And then downward, you percuss again until you hear dullness. You would mark that spot. It's usually around the fifth intercostal space. And the measurement should be between 6 and 12 centimeters for a normal liver. Then we want to do splenic dullness. We're going to percuss the spleen, on the left side, posterior to the mid-axillary line. You may hear dullness from the 6th to 9th rib. Okay, dullness right there. And then the next test you would do when you're assessing the abdomen is the gastric bubble. This is done by percussing in the area of the left lower anterior rib cage and the left epigastric region. The tympani produced by the gastric bubble is lower in pitch than the tympani of the intestine. Again, we're percussing. After we do percussion, you want to do palpation. First, you start with light palpation. This is to get the patient used to the palpation, especially if they're ticklish. It will get them used to the touch. And you're just going to use your fingertips, lightly palpate the abdomen, all 4 quadrants. You're assessing for muscle resistance, tenderness, and masses. When you're doing light palpation, you don't want to palpate more than 1 centimeter. After light palpation, you would do a deeper palpation. Again, using your fingertips, pressing down firmly, deep and even. Again, all 4 quadrants, feeling for any masses, any muscle resistance, any tenderness. The next test when you're assessing the abdomen is the umbilicus and the umbilical ring. You're going to palpate around the umbilicus, which is the belly button, and it should be free of any bulges, nodules, and granulation. And again, with the umbilicus, you can have an inversion or an exversion of the umbilicus. Then we're going to check for the liver border. We're going to place our left hand under the patient's 11th and 12th rib. And we're going to press up to try to elevate the liver. And then with the right hand on the abdomen, fingers pointing towards the head and extended so the tips rest on the right mid-clavicular line below the liver dullness. And that's feeling for the liver border. You can then try to palpate the gallbladder. You want to palpate below the liver margin at the lateral border of the rectus abdominis muscle. And normally a healthy gallbladder will not be palpable. If you can palpate it, it usually means that there's an inflammation of the gallbladder. Then we can try to palpate for the spleen. That's on the left side of the abdomen. I'm going to use my left hand, reach over my patient, and place it beneath his left costovertebral angle. I'm going to press upward with my left hand to try to lift the spleen. And then with my right hand, my fingertips, I'm going to press upward to see if I can palpate the spleen. I'm going to ask the patient to take a deep breath. Can you take a deep breath and hold? With my fingertips going upward, I'm trying to palpate the spleen. The spleen usually is not palpable. If it is palpable, that means it's enlarged and further diagnostic testing needs to be done. Kidneys, we can now try to assess the kidneys. Again, I'm going to reach across with my left hand and place my hand on his left flank. I'm going to use my right hand at the left costal margin. I'm going to tell the patient to take a deep breath. I'm going to elevate his left flank as I palpate deeply. Take a deep breath. Trying to palpate. And again, a normal left kidney usually is not palpable. The next test we do for assessing the abdomen is an aortic pulsation. We're going to deeply palpate slightly to the left of the midline and feel for the aortic pulsation. If a pulsation is present, you want to try to determine the direction of the pulsation. A prominent lateral pulsation suggests an aortic aneurysm. And then finally, we're going to do a costovertebral angle for kidney tenderness. I'm going to have my patient sit up. You can sit up with your legs over. I am going to place the palm of my hand over his right, well, actually I'm going to be on his left this time, his left costovertebral angle. And then I'm going to strike it with the fist of my other hand, the ulnar side. This should be, the patient should perceive this as a thud and really not as pain. It shouldn't cause any pain. And then again, I would do it on the other side. And this concludes the assessment of the abdomen. Thank you.
Cut that out of the video.